On behalf of Brazilian Society of Functional Neurosurgery, I'd like to thank everybody for our webinar. The audience has reached a huge number every week, and the lectures has been very informative and very productive, a good time for us. Our topic today is a spinal cord stimulation, and I will ask Dr. Paulo to present speakers and panelists. Dr. Paulo.
Thank you, Antonio. Welcome to everyone. I would like to thank you all to being here today and say how important is your participation is. Well, let's start now. Today's topic is chronic pain is a very common health problem worldwide and a major cause of disability and suffering. Chronic pain is a disease, but also a constellation of symptoms and affects people of all age, from children to elderly, being one of the most frequent reasons for medical consultations. Spinal cord stimulation has become widely used and efficient alternative for management of refractory chronic pain that does not respond to conservative therapies. Currently, technology advances in neuromodulation devices are extremely sophisticated and reliable in obtaining good results for various clinical situations of chronic pain. Talk to us today, we have a selected important group formed by Professor of Neurosurgical Science. Professor Daniel de Almeida is a neurosurgeon, head of Gamma Knife Department and Pain Treatment Group of Medical Residence Program, Neurology Institute of Curitiba, Brazil. Professor Murilo Marinho is a neurosurgeon at the Escola Paulista de Medicina, Medical Residence Program, Federal University of São Paulo, Brazil. And Professor Wilka Campos is a neurosurgeon at Neuron Clinic, Bahia Sul Hospital, and Celso Ramos Hospital, Florianópolis, Brazil. Many thanks to everyone for accepting the invitation for the Brazilian Society of Functional Neurosurgery. Professor Parag Patil. Professor Parag Patil educational background includes electrical engineer from Massachusetts Institute of Technology, philosophy and economics from Oxford University, as well as MD and PhD in biomedical engineer from Johns Hopkins University. Dr. Parag Patil currently serves as Associate Chair for Clinical and Translational Research in the Department of Neurosurgery at the University of Michigan. Professor Parag, the stage is yours.
Thank you very much. Let me just make sure that I can do this here. So, all right. Well, thank you. It's really a pleasure to join you, even virtually. I have some disclosures, though I imagine those aren't relevant, where I receive funds from the government for my research. Most importantly, I have wonderful memories of my last trip to Brazil, which was in 2011, and had the benefit of having a wonderful host in Dr. Brainer, and participating in the World Federation of Neurologic Societies interim meeting, which was held in Recife. And it was really a wonderful memory, and I look forward to coming again sometime. Today, I'd like to talk about spinal cord stimulation. And this therapy is a great success. There is a great deal of evidence to support the use of spinal cord stimulation in failed spinal surgery, in complex regional pain syndrome, in limb ischemia, in angina. And then there are other clinical studies that are done in a non-randomized fashion in other areas such as peripheral neuropathy, phantom limb pain, abdominal pain, pelvic pain, and post-herpetic neuralgia. So you can see that there are many applications for spinal cord stimulation. And in fact, there are 50,000 implants for spinal cord stimulation per year. The technology of spinal cord stimulation is advancing very rapidly. It was first introduced in the 1960s with the gate theory of pain, and we will talk about the science of spinal cord stimulation during this talk. The first commercial spinal cord stimulators were in the late 1960s, and really with the advance of computer technology, we've seen rapid advances since 2000 with the introduction of multi-contact electrodes, tripolar leads, rechargeable pulse generators, and so on. And we will talk a little bit about each of these today. I should probably, before talking about advances, talk about spinal cord stimulation itself. This is a technology in which an electrode is placed on the surface of the spinal cord, typically above the dura and below the lamina. The electrode is connected by a wire to an electrical pulse generator, which is like a pacemaker, which is placed underneath the skin, often in the buttock. This pulse generator can then be programmed to deliver electrical signals to different contacts on the electrodes at different frequencies, meaning the speed of pulses change, and at different strengths. And so the way that this technology has been advancing has been in each of these components moving forward. For this slide, I show some of the many different advances in lead technology. The important takeaway point is that there are many different shapes and sizes for these leads that can be used, whereas originally the lead was very simple with just one electrical contact placed in the spinal cord. In addition, the signals that are provided through this lead have changed very much. Originally, the signals were, as you see here in the top left, a very simple set of pulses. This has changed with the introduction of bursts, which is what you see in the bottom left, where there's a string of pulses followed by a rest. And also more recently with very high frequency stimulation, which you see on the right. Each of these appears to have some benefit in the treatment of pain, particularly in back pain and lower extremity pain. In addition, the electronics of the pulse generator have changed the same way that our computers have advanced. So now these stimulators can be MRI compatible. Each of the contacts can be stimulated independently. Some of the stimulators can detect the position of the patient, whether they're lying down or standing up, and adjust the stimulation accordingly. And in development is technology to be able to program remotely, just the way we use cell phones. These can also be used to program the stimulators themselves. But there's a warning, and that is from this author, Mark Twain, American author. And I'm sure there's a similar statement in Portuguese, which is that when all that you have is a hammer, everything becomes like a nail. And so what I would really like to spend much of the time today doing is talking about how to think about using this wonderful technology to treat patients appropriately but not to think that every nail needs to be hit with the same hammer. So the ground that I would like to cover today is divided into a number of sections. And I'm hoping that I'll be able to get through all of this within about half an hour to leave plenty of time for questions. I'm first going to talk about some 4 cases that are relatively common cases to think about how we use this technology. I'd then like to talk in general about the neurosurgical strategy for pain, particularly for those in the audience who are not experts. Then talk about the science of neuromodulation and the studies of particularly spinal cord stimulation. Then briefly discuss choosing among the available technologies. A very important topic is that spinal cord stimulation fails in some patients, and how do we manage that failure? And then what I'd like to finish with is introducing a little skepticism when we see evidence in the literature and how we need to think about it, and then some final thoughts. I'm hoping that I can give this talk at a level that everyone is able to understand, and I can see some of my colleagues in the corner, so you can signal to me if things are less or more easily understood. So let's talk about these cases, and we'll do some surveys. These cases are not meant to be complicated. They're the kinds of cases that many of us see on a routine basis. So the first case is a 35-year-old with a history of a left L5-S1 discectomy 2 years ago, who presents with initial relief, but then return of pain. The pain has a particular characteristic in that it comes on suddenly and dies away slowly, and the pain is in the same distribution as the prior pain problem. I'm sure all of us have seen this many times. There's a small amount of plantar flexion weakness and a small amount of numbness, and the patient has exquisite pain with straight leg raise. This is the T2 image, and you can see that there is some loss of the lamina from the prior surgery and some changes here. And with the contrasted T1, the problem becomes apparent that the nerve root is swollen and surrounded by considerable amounts of scar tissue. So the question to the audience is, assuming that the non-surgical therapy is optimized, how would you treat this patient? Either the patient is not a surgical candidate, the patient could be treated with spinal cord stimulation, or the patient should be treated with conventional surgery to remove the scar tissue and decompress the nerve root. So we'll put up the quick survey and see if people are able to vote.
Okay. The results.
All right. So a quarter said not a surgical candidate, a quarter said spinal cord stimulation, and half said conventional surgery. So this is very interesting because, in fact, there's considerable literature that in situations where there is a nerve root that is wrapped in this way with scar tissue, that conventional surgery is not going to work. Many patients are turned away completely from surgery because of that. But in fact, spinal cord stimulation can be quite useful. So let's go to the next case. A 60-year-old female with a long history of back pain, worse when standing, begins to have pain in her legs, worse on the right in an L5 distribution. More recently, she has developed pain in the L4 distribution as well. The pain is improved with forward bending, such as using a shopping cart. She had previous hip surgery, but the pain is different from that. The exam has some slight EHL weakness and a small amount of numbness. You can see on the X-ray that there is anterolisthesis of L4 on L5. And the MRI shows, oh, I didn't realize this was, the MRI shows foraminal stenosis, and you can also see the increased compression of the exiting root compared to the level above. So again, the question is this patient not a surgical candidate, a candidate for spinal cord stimulation, or a candidate for conventional surgery? So we should be able to pull up the poll.
I'm sorry?
The result came up from the prior.
Yes. Let me case 2.
Wonderful.
All right.
Okay. So 81% say conventional surgery, 19% say spinal cord stimulation. And in fact, in our center, this patient would be treated with conventional surgery. This would be a lumbar decompression infusion at L4-5, typically done minimally invasive. The third case, this is a 24-year-old woman with a history of a left ankle fracture. The bone healed, but she developed pain, redness, and cold sensitivity in her foot. On examination, you can see she has full motor strength, but she has exquisite touch hypersensitivity of the foot. She has trophic changes in her nail bed. And her strength exam is pain limited. So, and the MRIs are all normal. So is this patient not a surgical candidate, a candidate for spinal cord stimulation, or a candidate for conventional surgery?
Okay.
Very good. So a quarter say not a surgical candidate, an eighth say conventional surgery, and the majority say spinal cord stimulation. In fact, this patient has complex regional pain syndrome, which is treated very effectively with spinal cord stimulation. All right, last case. A 75-year-old with long-standing heart disease. complains of back and bilateral worsening lower extremity pain. He notes that using a walker or shopping cart seems to help. His pain is particularly worsened when standing and relieved by sitting. The exam is benign, though the patient has significant back and bilateral lower extremity pain when standing. And you can see that the patient will bend over a wheelchair. The MRI is, as you see, in the middle, and there's significant stenosis without antrolisthesis. And so the question is, in this 75-year-old with heart disease, is the patient not a surgical candidate, a candidate for spinal cord stimulation, or a candidate for conventional surgery?
Okay.
Okay, so there's no right answer to this patient, because of course it depends on how bad the heart disease is. What are the other risks? This patient in our center, the heart disease wasn't too bad and was treated with a minimally invasive single level decompression. But patients who have considerable pain, let's say they have scoliosis and they are not good candidates for highly invasive surgeries, sometimes spinal cord stimulation is a reasonable alternative to a more invasive conventional surgery. And thank you for participating. So I'm quickly going to talk about some neurosurgical strategies for pain. I think most of the audience is probably familiar with these issues. Of course, the first question is, what is pain? Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such a damage. The important issue there is that it's both sensory and emotional, and this will be important in our treatment of patients with spinal stimulation. The second component that's of great importance is the division of pain into nociceptive pain versus neuropathic pain. Nociceptive pain is pain from ongoing activation of nociceptors associated with tissue damage. Neuropathic pain is the abnormal sensation resulted from injury to the nervous system. Let's look at both of those in a bit more detail. So when we examine a patient who has pain, and we want to understand if they have nociceptive pain, then all we can do is talk to them about their experience. We know that nociceptive pain often responds to non-steroidal anti-inflammatory drugs and opiates. It often occurs with trauma or arthritis, postoperative pain, and visceral pain. And patients describe nociceptive pain as aching, throbbing, gnawing, beating, etc. By contrast, neuropathic pain is associated with injury or abnormality of the nervous system itself. It does not respond as well traditionally to opiates, though they can be used, and instead is treated typically with membrane stabilizers or antidepressants. Examples are radiculopathy, trigeminal neuralgia, CRPS, peripheral neuropathy, and so on. And patients describe these painful sensations as burning, tingling, prickling, itching, and cold. So the important thing to distinguish is the difference between throbbing, aching, gnawing, and burning, tingling, prickling. We have a number of words that we use to describe these abnormal sensations. I'm just putting them up on the screen so that you can see them. I think most are familiar. It's important for us to know these words or the equivalent in our language, because this will allow us to explain what the patient is experiencing to our colleagues and also to the patient. These words, paresthesia, dysesthesia, allodynia, they're all characteristic of neuropathic pain. So what is the strategy that we use as neurosurgeons? Well, of course, we have different prongs to the approach to pain. The first is if we can correct the problem, we would like to correct the problem. We might transpose a nerve, we might decompress a compressed nerve root, we may perform a microvascular decompression in trigeminal neuralgia, we may surgically resect a cancer. If we are unable to correct the problem, we may be able to modulate the pain signals through nerve root stimulation, spinal stimulation, motor cortex stimulation, or intrathecal opioids. As a last resort, we may destroy the signaling pathway of the nervous system from the area of pain to the brain using a neurectomy, dorsal root entry zone ablation, radiofrequency rhizotomy, or one of my favorite operations for cancer pain, which is percutaneous radiofrequency cordotomy. And so when we're thinking about the use of spinal stimulation in the context of our patients who have pain, we want to think in terms of these steps. If we are able to correct a problem safely, that is always preferable to spinal stimulation. However, if the risks of the correction, if the extent of scoliosis, if the age of the patient and so on are not favorable, then we should keep in mind the possibilities of neuromodulation for that patient. So let's talk about the science. There are a number of SCS modalities now in 2020. There's traditional stimulation. There's higher frequency stimulation, which is at 1 kilohertz. There's still higher frequency stimulation at 10 kilohertz. There are novel stimulation waveforms such as burst. There's refined stimulation targeting towards the roots and DRGs. And also now there's the introduction of closed loop spinal cord stimulation, where the signals are sensed and the strength of the stimulation is adjusted. None of the mechanisms are understood well enough to guide rational therapy. And therefore, all the results are empirical, and each company producing one of these devices believes that they are the best and would like to convince us that they are the best. And therefore, it is up to us as providers to understand the evidence and also to be able to choose well for our patients. I'm going to go relatively quickly through the science for reasons of time. I think most of you are probably familiar with the traditional gate theory of pain. The idea is that electrical stimulation of A beta fibers, which are myelinated fibers, act to close a gate on the signals coming in through C fibers. This was the traditional understanding of how spinal cord stimulation works. The gate theory was very useful because it provided an explanation for spinal cord stimulation mechanisms and gave us some understanding of how adjusting the parameters of stimulation could change how patients experienced it. The problem is that the gate theory really doesn't hold up very well. It doesn't account for the fact that, for example, spinal cord stimulation can fail even when there's stable maintenance of the paresthesia. So the patient still feels the tingling, but the pain is no longer relieved. Also, neurons only fire up to about 1 kilohertz, and that's in the auditory nerve. So we really can't explain high frequency stimulation, such as 10 kilohertz stimulation, with the gate theory. Finally, the gate theory does not include temporal coding, changes in the pattern of firing, or impacts on downstream or central structures, and so cannot explain why something like burst stimulation works compared to tonic stimulation. So the science needs to advance. We have a number of clinical trials that help us to understand that these different things work, and I'm going to review them quickly. In 2007, Dr. Kumar published the process trial. This was of traditional stimulation. He showed that compared to conventional medical management, spinal cord stimulation achieved much better results. In addition, follow-up studies when we developed different multi-column spinal stimulators showed that there was an improvement of multi-column spinal cord stimulation versus conventional medical management. So spinal cord stimulation clearly works in well-selected patients over medical management. As new stimulation patterns have come about, people have tried to compare these newer stimulation formats to the old traditional stimulation. So North, in an excellent paper in 2016, did a crossover trial of traditional and 1 kilohertz subthreshold stimulation. So this was stimulation that was delivered in such a way that the patient did not actually feel the stimulation, but still had benefit. And what this showed is that with a higher frequency stimulation, even when the stimulation could not be felt, that patients experienced improvement in their pain. With traditional stimulation, unless the patient feels the stimulation, they do not experience the benefit. The Senza trial in 2016 presented a comparison of traditional stimulation to high frequency, meaning 10 kilohertz stimulation. This study, which was a randomized controlled trial, showed that there was an improvement in terms of back pain with the high frequency stimulation compared to traditional spinal cord stimulation. This was a particularly well-constructed study in that it was randomized and it was also controlled. Burst stimulation, which was introduced by de Ridder, has a different scientific basis, which is that by having a high energy burst, it is believed to modulate more central pain processing and possibly even modulate affective pain processing. Whether or not you believe that that is the case, the clinical trials, the Sunburst trial, demonstrated that comparison of tonic and burst stimulation with an open label randomized crossover study showed that burst stimulation provided improved pain control with lower degrees of paresthesias. So to summarize the spinal cord stimulation findings, traditional spinal cord stimulation must be felt for it to work. With higher frequency, whether it's 1200 hertz or 10,000 hertz, or burst stimulation, can be delivered at an amplitude where the patient does not feel the stimulation, but still experiences pain relief. This suggests that these other waveforms are beneficial due to a different mechanism of action. Finally, the DRG or root stimulation has been practiced with conventional electrodes for many years, but now there are specially designed electrodes which can be placed to stimulate the root or DRG. And the accurate study showed that this was particularly useful for patients with causalgia or CRPS2. So where are we now in terms of the evidence for spinal cord stimulation? And let's focus on failed back surgery and low back pain. We know that traditional works, typically the leads for low back pain are placed at T8 or T9. For burst, it's higher energy and patterned. It also is typically placed at T8 or T9, but can be of lower amplitude. But the amount of energy being delivered to the spinal cord is much higher with burst. With 1,000 hertz or 10,000 hertz stimulation, it appears that the effect may be a little bit lower down. The studies with 1,000 hertz stimulation tend to be due to readjustment of already placed systems. So the stimulation tends to be both at T8 or T9. But with 10 kilohertz stimulation, the electrodes are intentionally placed at T9, T10. It suggests that perhaps for high frequency stimulation, the site of action is at the root entry zone. All of this is to say that different forms of stimulation have their effects by acting in different places in the nervous system. Root stimulation acts at the root. 10 kilohertz stimulation may act where those low back pain fibers enter the spinal cord. And lower frequency stimulation or burst may act on the dorsal columns or even transmit signals up to the brain. I won't talk about supraspinal and descending mechanisms because it's a rather complicated topic. However, I think it's important for us as neurosurgeons to understand that pain modulation is not just a matter of changing the signals going from the periphery up to the brain, but also we may be able to affect the way the brain receives those signals or the way the brain suppresses those signals. And this is going to be an area of study in the future. So how do we choose among these various spinal cord stimulation therapies? The science is there, and all of them are safe and effective. The clinical data shows that all of them may be used as a starting point for therapy, but that all of them experience treatment failures during the trial, because of course spinal cord stimulation is done first as a trial, then as permanent placement, and all of the modalities experience some level of long-term failure. I've had the experience of initial patients with each of these therapies failing a trial, and then the patient experiencing benefit from a different modality. It isn't consistent. There isn't one silver bullet that works for all patients. And so therefore, whatever the advertising or marketing materials say, there's no real basis for choosing among them in advance, though I'm going to give you a few pearls at the end. There are broad indications, as you can see. And I really want to emphasize the importance of patient selection. Recall that we talked about pain being an unpleasant sensory and emotional experience. Patients who experience chronic pain necessarily have psychological effects due to this pain. And therefore, even as neurosurgeons who are not trained as psychologists, it is extremely important that we pay attention to the psychological risk factors, whether they're depression, which prevents a patient from enjoying the benefit of pain relief, even if their pain is relieved, or substance abuse in the form of opiate dependency. These are things we have to think about as neurosurgeons, because if we don't think about them, first of all, we will do surgery in patients who will not benefit. And also, as we all know, once we operate on a patient, they are our patients forever. And so an unsuccessful therapy is not something that we want to have as something that we need to deal with on an ongoing basis. There are some types of pain that are simply not good for spinal cord stimulation. One is cancer pain in which the location of the pain is not stable, where the region of pain is spreading. Cancer pain can be treated with spinal cord stimulation, for example, in patients who have injury to nerves that is stable due to therapies for cancer. Spinal cord stimulation does not work for nerve root avulsion. If a patient is insensate in a region, spinal stimulation is unlikely to help them. Osteoarthritis, hip problems, knee problems, these do not benefit. And also, except in rare circumstances, visceral pain, also such as pain associated with endometriosis, does not benefit from spinal cord stimulation. As I mentioned, and I can see that time is running quite quickly, failure is not uncommon. There's an explant rate of 8% per year in spinal cord stimulation for a variety of reasons. This is very important for us to consider because of the costs that are associated with having to remove a spinal cord stimulator for the patient and for the healthcare system. The primary reason for failure is a loss of efficacy. That is 40 to 70% of patients. And it is a loss of pain relief without evidence of hardware malfunction. And the half-life is about 12 to 15 months. So in order for spinal cord stimulation to be worthwhile, we have to understand why these failures are occurring. And to cut to the answer quickly, we still don't know what the answer is. It may be due to a change in the patient's condition. It may be due to a change in physiology. But we simply don't know at this point why these patients fail. This is because we don't still understand how spinal cord stimulation works. We don't understand how electrical stimulation relieves pain. We don't understand the site of action. And we don't understand why spinal cord stimulation fails, even if paresthesias remain unchanged. In addition, pain patients, the population is very heterogeneous. So large prospective clinical studies are difficult, and where they're done, there's a clear commercial interest. The clinical studies summarize empirical observations rather than testing fundamental hypotheses, and follow-up duration is short. So when we're reading these papers in our literature, we have to be thoughtful about how we scrutinize the evidence. And I want to provide you with two thought exercises. The first is of a crossover study in which a patient is randomized to first one type of stimulation and then another type of stimulation. The exciting finding is that 70% of patients have pain improvement with the first type, and 90% of patients have benefit with the second type. And the conclusion of this fictitious study, but you'll see many such studies in the literature, is that in this random crossover trial, stimulation type B appears to be better than stimulation type A. And so therefore, we as clinicians want to use type B. Another study, a patient fails one type of stimulation and switches to another type of stimulation with follow-up at 6 months. At 5 months, 80% of the patients with the new stimulation have sustained benefit. So the conclusion is that spinal cord stimulation B is able to rescue spinal cord stimulation A. I'm going to get just a little technical for a minute because I want to show you how these two studies work and how they might mislead us. So here is the result for study 1. We see that group B has 90% benefit, and that appears to be sustained over time. That group A has 70% benefit, and that is sustained over time. But if we look over a longer period of time, these are the same exact curves that you are seeing here. What happens is the one therapy starts high and then goes low, while the other starts low and is sustained over time. And so depending on how the therapy is working, we can reach very different conclusions. If the study had gone long-term, it would conclude that group A does better than group B. If the study is short-term, it shows that group B is better than group A. And so we always need to keep in mind the time scales of loss of efficacy. And no studies are done for the number of years. Remember, the half-life is 1.5 years. So no studies are done long enough for us to know these differences. In the second case, here are the two actual curves. They're both exactly the same. So what happens here? In this case, the patient experiences benefit initially, which declines over time. Then they switch to the other therapy, which gives them a bump, and then that declines in the same way. But because of the way the study is put together, the patient appears to have a benefit or a rescue from the one therapy over the other. So there are many, I should say, very well done studies that have very intriguing results, but ultimately don't provide us with as much information as we would like to know. So everything appears to rescue everything else, and no modality avoids the loss of efficacy completely, and no studies are sufficiently long-term to form conclusions that provide us with the answers that we really need to know. So in terms of final thoughts, here are my clinical pearls that I keep in mind for my SCS practice. First is that arthritic pain, whether it's from the back, from the hips, or from the knees, does not do well with spinal cord stimulation. It is pain that has a neuropathic rather than a nociceptive quality that tends to do better. Intermittent pain does not do well with spinal cord stimulation. If a patient has lumbar stenosis and that stenosis pain comes on suddenly in a stab when they stand up, this is not a patient who's going to benefit from spinal cord stimulation. Continuous neuropathic pain, by contrast, is much more responsive to neuromodulation and spinal cord stimulation. Also, we need, even if we're the last resort, we need to be judicious in moving from a trial to permanent placement. If the trial is not a slam dunk, then the patients tend not to do well long-term. Opiate dependence has been shown in studies and in practice to increase the chances of explant. Even as small a dose as 30 to 90 milligram equivalents of morphine per day significantly increase the chance of explant. And so if it's possible, one should try very hard to reduce opiates before doing a spinal cord stimulation trial. And finally, I will repeat again, even as neurosurgeons, the psychological evaluation is absolutely critical. Patient selection is key, and understanding their psychology is going to determine your success more than the quality of the surgery that you do. In my practice, I iterate. So if there's a patient, I see whether they have single root problem, whether they have a generalized problem, and then I choose one of these therapies. But I'm not afraid, if the insurance company will allow me, to try even 2 different therapies during a single trial, and then allow the patient to decide which one is better for them. So in conclusion, what can we expect in the future? We need to evaluate patients to reveal the underlying pain mechanism. We need to choose the modality that addresses the underlying pathology. We need to study multiple modalities during an extended trial period to figure out what works best. And hopefully future studies will be extended to longer follow-ups, even a 30-month break-even point. And hopefully we'll be able to develop and validate biomarkers for pain and analgesia, which will allow us to have more objective measures of our problems and our solutions. There's much work to be done. I'm sorry I went a little over in terms of the time I wanted to spend on the talk, but I'd be happy to stay on longer and answer any questions. I think you might be muted, Paolo.
Now I need to turn on my microphone first. Thank you very much. It was a lecture to make think about real experience and knowledge. Really, congratulations. I will strongly recommend your class for all residents in my hospital. Well, I'd like to invite Dr. Daniel de Almeida for comments and questions. Professor Daniel, please.
Hello, everyone. My first talk is to congratulate you. Wonderful. I really appreciate it a lot. And I would like to start from the end. You said we had, I used to say that in the past, it was easier to buy a car because we have we didn't have a lot of choices. So to choose a car, it was easier. I would start by you said that you consider the patient dorsal root burst. I would like to hear a little bit more about that. I mean, like, let's say that dorsal root stimulation you would choose for those patients with a root problem. But for those who do spinal cord stimulation, when do you choose to go to a burst, a high frequency, or a conventional?
Yeah. So this is an excellent question. So with respect to dorsal root stimulation, I've been very happy with it for regional pain, for groin pain. You know, it tends not to work as well for scarred nerve root pain because of the difficulty of getting the electrode close to the nerve root. For spinal cord stimulation, I tend to find that the subthreshold stimulation is helpful to patients, and they like having stimulation that they don't necessarily feel. But then I do have patients who like traditional stimulation. So typically what I'll do and in terms of this is purely surgeon preference. This isn't therapy evidence. But I tend to like the penta electrode in terms of its stiffness and its size. And so for patients with traditional failed back syndrome, I'll often use a penta. I do percutaneous trials, and then I do laminectomy placement to avoid movement. But the percutaneous trial, I'll have them try both traditional stimulation and burst stimulation in the case of Abbott. I'll have them try both traditional stimulation and high frequency stimulation in Medtronic. I'll have them try, I'll have the rep try different things. Because I personally tend to like that one electrode, paddle electrode, I tend to do more Abbott trials for back pain, but I've been very impressed with some of the results that we've gotten with Nevro, with the high frequency stimulation as well. So I can share what my personal preferences are, but there is not an evidence-based way to choose among them.
Daniel?
Ask a second question or later? We can.
Yes. If you prefer, do now or again, it's up to you.
Well, my second question is about psychological education. I don't know if you want to do now. I've seen that you are interested in a lot of different things, not only medicine, but economics, philosophy, and so. I would like to change the topic because I'm sure that nowadays doctors are very familiar to technology and so on, and we are less aware of how psychological intervention should be focused. So I would like to try to hear from you, as you're interested in philosophy and things like that. What can we do to improve psychological education for doctors nowadays?
Yeah, it is very difficult. It's hard for a neurosurgeon to also be a heart surgeon, right? There's reasons that each specialty is there. I will say that I am very spoiled at the University of Michigan because we have a pain neuropsychologist who is very experienced, who is able to either come to the clinic and evaluate that patient with me, or we can send the patient for a full evaluation before their trial. I recognize that this is a luxury that does not exist in many places. Partly because of time and partly because of resource. And so I think that if we can increase awareness among, a simple screening for depression, simply asking the patient, how has the pain affected your mood, right? We don't even ask that question. How has, aside from the physical things, how, do you sleep well? How much medicine are you taking? If you miss your medicine for a day, do you get the shakes? I think it's unrealistic to try to develop all the skills of a neuropsychologist, but maybe if each one of us can have 2 or 3 screening questions that we ask patients and think about, that may be useful.
Thank you very much. Let me, Danielle, we turn after all panelists, okay? Please keep with us. I would
I'm here for you.
Thank you.
Yeah.
I would like to invite now Professor Murilo Marinho, for your comments and questions, please.
First of all, thank you, and I would like to congratulations first the society for this brilliant idea to make these webinars, and also thank you, Dr. Paris, for your brilliant lectures. Daniel have done a lot of my questions, and I try to to go for more technical point of view. You said that you prefer the pedal electrodes, most of our patients. It's difficult to decide how kind of stimulations you start with these patients. But during the operations, having used some intraoperative monitoring, like collision techniques or some another kind of technologies for the best position of the leads?
Yeah, no, thank you for that question. It's an excellent question. So when I started in 2005, I was very traditional. I would wake up the patient. I would essentially put the patient to sleep. I would put in a lot of local anesthetic. I would wake up the patient. I would do stimulation testing and so on. This was incredibly hard on the patient. This was incredibly hard on the anesthesiologist, and it was incredibly hard on me, but I felt that it was a necessary evil. Maybe 8 years ago, we developed a team who does intraoperative monitoring, and particularly very good EMG monitoring. So now all of my surgeries are done asleep. It's typically done with a half MAC of isoflurane plus propofol or the anesthesiologist's choice. And it's the same across patients. We do not wake up the patient. I use EMG to determine the sidedness of the electrode. With the paddle electrode, I look in the middle column, and typically with a 450 microsecond, so a wide pulse, about 50 to 60 hertz, and amplitudes which may even be like 8 milliamps or so, you can get motor changes often in the gastroc, and I will use the symmetry of those motor changes to determine whether my paddle is in the physiologic midline. This has been reliable enough that I've never had a paddle that was off to the side because of this, having the patient asleep. And so I now always do the laminectomy asleep, and the patients are grateful for that.
Thank you for your work. My second question is about the results. How can you improve your results? I mean, about the measurements about your results. Do you use ever now you haven't seen the papers that you are more involved in objective measurements?
Yeah.
How do you use in your practice?
So it is very difficult to study patients long term, because the patients who are successful, the last thing they want to do is return to their doctor's office. They want to go and have their life. And the patients who aren't doing well, they of course will call you unless they've lost faith, and then they disappear. And so, what I do essentially is I tell patients that I'm your doctor, I'm always your doctor, I'm always happy to be helpful, and then ask them to follow up over time. But it hasn't been possible for us to get the kind of systematic follow-up that we would love to have. I think in Europe it's better, where systems are more closed, and so essentially the primary care is integrated with the specialty care, and patients essentially get all their care in one system. So it's easier to follow patients over time, even if they're lost to follow up with the neurosurgeon. But I would say we don't do a particularly good job of it, but we do the best we can.
Okay, I think I'm done for now.
Thank you, Professor Murilo. I would like to invite now Professor Wilka Campos for comments and questions. Professor Wilka.
Thanks, Paulo. First of all, congratulations for your interesting lecture and large overview of this spinal cord stimulation. And my question is about some patients that prefer traditional spinal cord stimulation. We know about this patient sometimes has a loss of efficacy of stimulation or efficacy of therapy, spinal cord stimulation therapy. So what your strategy in terms of programming of this patient, specifically this patient? You change of sensorial accommodation, changing the frequency, and then you change the sensorial neural experience?
I'm not sure I followed the question exactly. Are you saying when someone has traditional stimulation and they lose efficacy over time, how do I try to rescue it?
That's it.
Yeah. So with traditional stimulation, the critical question is, does the patient experience the paresthesia in the same location that they did before? And if they're experiencing the paresthesia in the same location as before, and they are not experiencing pain relief, then I don't think that adjustments in the traditional domain are going to be very helpful. Sometimes I'll try to, I'll never explant a system unless the system has been turned off for a period of time. And you'd be surprised how many patients say the spinal cord stimulation isn't helping them. You turn it off and they come back and they say, oh my gosh, it's actually helping me, you know. But I'll typically switch to a different modality. So with most of the stimulators, they can go up to 1200 Hertz. And so I'll switch from traditional stimulation to 1200 Hertz to see if that can work. If a patient doesn't work on 1200 Hertz or traditional stimulation, that's when I might say, well, you know, can I change the IPG and put them to a different form of stimulation? Or can I do essentially a trial through the old lead? So I externalize the wires with an extension and hook it up to a Boston Scientific IPG or a Nevro IPG to see if I can rescue it. But I don't think that things like adding baclofen or, you know, these sorts of things are consistently helpful. What has been your experience? Have you found something that works consistently?
Yeah, in my experience, sometimes I change of frequency, and then I can get again the pain relief change. Sometimes 14 Hertz or 80 Hertz, and then change of this rating.
Yeah, no, and so I think that, you know, when that works, it's wonderful. It's very hard to know, you know. That's the thing, and this is part of the problem. Part of the problem is that every patient is different, and their neurophysiology is different. And so, you know, there's a saying, you know, if you've seen one patient, you've seen one patient. You can't extrapolate very easily from one patient to another patient to another patient.
Yeah, I agree with you.
Thank you for your question.
Thank you, Antonio. If you agree, we have a time to another round.
Okay, go ahead. I think the discussion is great.
First of all, I would like to do an audience question. Our friend Clement, he asked, our question is, with the opioid crisis, do you think there is a room for an increase in the use of neuromodulation or lesions for nociceptive pain, as was the case in the past?
Oh, that's a great question. And of course, Clement would be better to answer the question than me, probably. But so this is the question. So the question is, if we want to reduce opiate use, how do we do that? One way is to continue to use opiates, but have them delivered intrathecally. If there's less control, less chance of abuse, less side effects. But let's leave that aside. So the use of intrathecal pumps. I think in the case of back pain and lower extremity pain, that neuromodulation has a role, but so far, none of the technologies make neuromodulation work where it previously didn't work. And so the patients who have true nociceptive pain, so they have hip arthritis or something like that, these patients aren't benefiting from neuromodulation. So I think there's a margin where certainly, let me back up. So the penetration for something like spinal cord stimulation is very low. The number of appropriate patients who could be treated with spinal cord stimulation who are now treated just with opiates is very high. So there's a lot of potential for patients to get spinal cord stimulation instead of being treated with opiates. But I think that spinal cord stimulation works on certain things and it doesn't work on other things. And so far I haven't seen anything where spinal cord stimulation works where previously it didn't work. Though coverage of back pain has gotten much better with some of these new technologies.
Well, Professor Daniel, feel free to ask some questions or comments, please.
Thank you. So let me ask one further question, one last question. You said that you prefer, in many cases, pedal leads, but you start trial with the percutaneous leads.
Yeah.
We all know that pain patients are challenging. And they very often, I heard a lot of patients that said, you gave me a stimulation different from the trial. And he said, I like that one I had in the past. And this is not the same. It was a little bit more lateral. It was a little bit more medial. It's not the same. I'm quite unsatisfied with what you gave. My question is, do you have this kind of situation? I mean, like when changing from one technique to the other?
Yeah, and so this actually is related to your earlier question. So sometimes, so let me answer first a serious thing and then one thing that's maybe a little less serious. So I do percutaneous trials because they're much less invasive. If a trial is done percutaneously, it can be done in the clinic. The lead can be removed in the clinic. And I think that by and large, the coverage provided by a paddle lead is usually better than the coverage provided by a single, percutaneous lead or a pair of percutaneous leads. So I'm betting that the risk to benefit ratio of the percutaneous trial is favorable compared to doing a paddle trial. So that's why I do percutaneous trial. But I have colleagues at my own institution who, if they do a paddle trial, if they want to do a paddle, they'll do a paddle trial. If they want to do a perc lead, they'll do a perc trial, and they're convinced that that is the right thing for them, and maybe it is. Sometimes I think the best way to see if a patient is a good candidate is to put, I don't know if you can see my water bottle. You put something like this in front of them and you say, is this half full or is this half empty? And the ones who say it's half full will be better candidates than the ones who say it's half empty. And in fact, we have now done a study with deep brain stimulation for Parkinson's disease with a formal cup half full, cup half empty. And lo and behold, patients who view the world as cup half full are more satisfied. So it is a fact that all of us as human beings, if we are suffering and some of that suffering is removed, we want all of that suffering to be removed. And so I think if we can set expectations clearly in the beginning, say that, look, my goal is not to cure you of your pain. You will always have pain, but I want to move your pain from being unbearable to bearable. That's what I tell my patients. My goal is you have unbearable pain now. I want you to have bearable pain in the future. And the ones who say, well, it's a little to the side, well, it's to the other side, then I say, well, you know, there's no way for me to fix that and guarantee that the outcome will be better. And so I don't think it's worth the risk.
Thank you. Clement, I'm sorry, Antonio. Professor Antonio.
Dr. Parag, was great lecture. But you said in your lecture that patients with scoliosis could benefit using the spinal cord stimulation. But seems to me that scoliosis is more mechanical pain, a more nociceptive pain. Don't you think the intrathecal pump would be better option in such case?
This is an excellent question. So let's talk about intrathecal pumps versus spinal cord stimulation first, and then we'll talk about scoliosis. So so intrathecal pumps are delivering opiates locally, as you know, with much higher local concentration of opiate. So an intrathecal pump will work for opiate responsive pain in which the patient is experiencing adverse effects of oral opiates. It will not work, and I know that you know this, but it will not work in patients who don't have opiate responsive pain. Spinal cord stimulation really is much more for neuropathic pain. So the patient with scoliosis, for example, that I'm talking about, is the patient who might have polyradicular pain due to the scoliosis and foraminal stenosis, but is too frail to consider a large decompression and fusion, let's say. I also, for example, am not, I do a lot of minimally invasive surgery with the tubes. And so if someone has scoliosis, but has dominant pain in, let's say, one root distribution, you know, I might do a small, very focal decompression to try to decompress that root and relieve that patient's pain. And I would do that before spinal cord stimulation. So patients who have opiate responsive pain, they benefit from the pump. Patients who have neuropathic pain are the ones that I consider spinal stimulation in. I'll give you two other caveats. One is that I tend to find that the patients who do well with pumps are the little old ladies who take a Percocet, get woozy, and are at risk of falling down and breaking their hips. The young person who is active, you know, but opiate dependent, I think tends not to do as well with a pump. In terms of the spinal stimulation, the one thing I would say is that you have to be very careful in a patient with scoliosis in terms of putting in a spinal cord stimulator, particularly if the patient has a previous long segment fusion, because sometimes getting the lead in to do the trial is challenging. Sometimes there's rotation of the spinal cord, so getting coverage can be difficult. So this is not something that I would suggest that anyone try generally in their practice, but in very specific situations, it can be very helpful.
Okay, that was my question. You did great.
And another audience, very interesting question. Okay. axial coverage has been the holy grail of SCS, and perhaps the single greatest point of contention between implanters on techniques, lead types, and contact configurations. Do you believe that SCS burst or SCS high frequency is superior to conventional SCS to that kind of patient?
Oh, so the simplest, most truthful answer is I don't know. Nonetheless, what I will say is I have patients where there are very interesting results with these different waveforms. I'll give you one extreme example. So I have a patient who had terrible glossopharyngeal neuralgia and had microvascular decompression and had success and then lost benefit and developed continuous neuropathic pain. We did a high cervical stimulator and was able to get some coverage, but no pain benefit. We then put in burst, and the patient was able to get essentially complete pain relief with subthreshold stimulation in burst. Now, I have no idea why that works. I know that it does work, and I know that I tried it because I had nothing else to offer the patient. So axial back pain, I do believe that burst, 10 kilohertz stimulation, 1000 hertz stimulation, these tend to work better for axial back pain than traditional 50 hertz spinal cord stimulation. What I can't say is why they work better or which one works better. I think that the 10 kilohertz stimulation is working because of activity on some sort of channel at the root entry zone level to block pain transmission, and that's why the leads are put lower. I don't know how burst is working. I don't think it's working through the same mechanism as traditional spinal cord stimulation, but I personally don't necessarily believe that it's acting centrally either. And so for my patients with axial back pain, they get burst or 10 kilohertz or 1000 hertz stimulation. And there's so then the question is 1000 hertz different than 10,000 hertz? And of course, there are some studies that seem to suggest that it's pretty similar, but then there are others that say that it's not. And I think the answer is still out on that.
We have another question from audience. It's a long question. I tried to resume, but it's about our colleague would like your comments about the Dr. Kumar's papers in 2006 with 410 patients over 22 years clinical practice. He found a significant improvement in pain in patients treated with traditional SCS. One happened with 2 years of diagnosis. The success rate was 85%, decreasing to 9% if the SCS was delayed more than 15 years after the onset of pain.
Yeah. So this is, I mean, congratulations to the person asking the question about their understanding and careful reading of the literature. And that question really underscores something that we know, which is that pain treated well and treated early, the patient does better than pain that is left for longer periods of time. And so the question then becomes, why is that the case? The aim of the study was to compare spinal cord stimulation with conventional medical management. And then this additional analysis was essentially a subgroup analysis of that. I think it meets with our intuition, but you know, what I would say is that what we learned from that study is that we need to identify these patients and treat them appropriately as soon as we can, rather than have them lie fallow. For every patient who is treated with spinal stimulation appropriately, there are probably at least 7 others who could be treated with spinal stimulation but are not. The problem is that we don't know how many patients who are not good candidates for spinal stimulation are treated with spinal stimulation, who don't have good indications. And unfortunately, at least in the United States, this number depends a lot on how doctors are compensated for their practice. So if the compensation for trials is very good, then the number of trials goes up. If the compensation for trials is poor, then the number of trials go down. I don't think that doctors are not conscientious. It's just that when all the directions are lined up in one direction, then people tend to use something. I don't know if that answered the question.
Yes, you answer. I believe that. I hope so. But I would like to ask Professor Wilke if you have any comments and question. Wilke, Professor Murilo.
Yes, I have one. Everybody knows at the end of the day, you take care more about the results, especially in the long time follow-up. You have some experience in hybrid systems, especially in those patients who fail. And just to continue this idea, how do you think about the cyclic stimulations? Do you believe, especially in high density, high frequency, or even burst stimulation? Do you believe that you need to keep like a 24/7 stimulations, especially in those kind of new waveforms?
Yeah, there are a couple of questions wrapped together there. One is there plasticity in the nervous system? So for example, if you turn on high frequency stimulation, the effects are not immediate. And so if you take a patient and you do a trial with 10 kilohertz stimulation and you ask them in 5 minutes, is your pain better? They'll say no. With traditional stimulation, if you turn it on in 5 minutes, they'll tell you an answer. Similarly, if you turn off the stimulation, then the opposite occurs. So there definitely is a certain amount of memory and plasticity going on. This is identical to deep brain stimulation when we're looking at pallidum versus thalamus and so on. So so for these systems that have memory, it probably is not necessary to keep stimulating all the time. What isn't known is what is the optimal balance in terms of that stimulation. So for example, even with traditional stimulation, does the patient need to have the stimulator on when they're sleeping, right? When they're lying in bed, there may be no pain generation. There's no need to have the stimulation. So I think what we're going to learn over time is what the appropriate or optimal rates are going to be. And I think that burst and high frequency stimulation, HF10 stimulation, doing them intermittently will work because their effects are long lasting.
Professor Daniel, Professor Antonio,
I'm okay.
any question or comment? No, I would like to say that to the audience that I would like to inform everyone that as soon as possible, all of the sections will be available on the website of Brazilian Society of Neurosurgical or Functional Neurosurgery. And many persons in the audience are asking about that. This is an important question. I would like to thank you, everyone. Dr. Professor Antonio Almeida, our president, could you
Just
finish our works, please?
okay. Dr. Parag, I would like to thank you. It was a great lecture, a great discussion after the lecture. You really took all the questions and was very clear in your answers. And it was very good for us. Okay, so thank you very much, and thank the audience that participate with questions and everything. And the next week, we'll have another lecture here in our society.
Yeah.
Thank you all. Bye.
And thank you very much for inviting me. I have to say, I think that this is a brilliant idea and a wonderful format, and just congratulations to you on that. And, you know, to take advantage of this crazy time that we all live in to come closer together and to learn from each other. I feel somewhat guilty because I know that I can learn from each one of you. You have such enormous volume and experience in Brazil compared to what we have in the United States. And I know from my friend Clement, you know, how much opportunity there is for research, and what a wonderful academic environment there is in Brazil. And so it's really been an honor to participate in this. And you know, I suppose if it's in Portuguese, I won't be able to follow very much, but if there are ones in English, I'll try to tune in.
Actually, the English is today the language of the world of science, so everything has to be done in English. It's good. Thank you so much.
Parag, let me say, you show me the best definition of best practice.
Thank you.
Thank you very much.
Thank you.
Keep going. And thank you very much. Thank you very much, Daniel. Thank you very much, Murilo, Wilke, and everyone.
Wonderful
See you
lecture.
soon.
Congratulations.
Yeah. Bye.